Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. Today I'm excited to welcome Dr. Matt Heintzelman onto the podcast. Matt actually was a professor of mine when I was at Lebanon Valley College. He was a evidence-based instructor, taught some evidence-based courses, and here I am talking with Matt today about evidence-based practice. What does it mean? What does it look like? And how can we implement that on the PT side on the day-to-day? So Matt and I have a great discussion today, and I know that you're going to love this episode, so enjoy. Matt, welcome to the podcast. I'm super excited to work with you today. Thanks for being here.
Yeah, sure. I'm excited to get going and good to kind of catch up on an LVC, Lebanon Valley College PT alum, and see what you're up to and hear all the good things you're doing.
Yeah, definitely. I appreciate it. It's been great to chat with you so far. For people who might not be familiar with you, or maybe they haven't heard of your work at the LVC PT program or other places in the world of orthopedic PT, would you mind filling them in a little bit about who you are and what you do?
Yeah. Well, that could be quite the story. So I'll try and get to the main highlights of it. So I've been University of Scranton graduate physical therapy program with a bachelor's degree back in the day in 1990, and then went on after working about 5 years to get a master's degree in information science back in 1998 from Penn State University. Thinking was this computer stuff might be something at some point, and I should learn a little bit about it. So I often got a master's degree to kind of combine that with my healthcare experience. Did the transitional DPT through Temple University, a great program there. And then since then, over the last 30 plus years, it's just been working as a physical therapist. So, probably the areas that I excel at or have the most interest in are orthopedics, chronic condition management, chronic persistent pain management, complex cases. But I've worked across all fields of physical therapy, and maybe we can talk about that a little bit. As a profession, it's just fantastic of just the opportunities you can kind of create for yourself if you're willing to just kind of say yes. I've dove in and currently working on an independent contract with a local school district doing pediatrics. And then, our other part of my day is coaching some runners and triathletes, and then also working with some kind of chronic persistent pain clients. So I've done kind of the whole smattering of things, which I think it all kind of contributes to being a physical therapist.
Definitely. It certainly seems like you've covered everything there, Matt. But, the one thing I'm surprised you didn't bring up is you didn't brag about yourself in a certain manner that I expected you to mention. So I'll brag for you. You're too
All
humble.
right.
You're one of the few people I've met who was an orthopedic clinical specialist, board certified, and then didn't renew, and then decided, you know what, I'm going to get the certification again. I liked that exam so much, I'm going to take it a second. You're one of the few people I found who has done that, and that is very impressive to me because I found a lot of people get it, and after about 10 years, they say, you know what, I don't need this anymore. But I like the fact that you went out there, I think just last year, and
Yeah.
renewed it. That shows a certain level of dedication that I know most of us don't have.
Well, you could call it dedication. Some people might say I'm stubborn. I'd gotten it back in 1998. One of my classmates, it was actually kind of on she bullied me into doing it because she was taking hers, and she didn't want to pass and then have to go all the way out to Seattle for CSM to get her award. So she's like, you do it. So I went and you know didn't really prepare very much. And somehow I managed to get a passing score and held that for 10 years. And then realizing it was probably, earlier than anybody was really paying attention to anything like that. Didn't change anything in my job. None of my employers recognized it. Certainly patients, clients didn't really care or recognize it. So there really wasn't a lot of value in kind of putting in the time and effort to do the renewal. And then, through the last couple of years, people would look at kind of my background and wonder, how can you work in outpatient orthopedics? You don't, how do you know what you're doing? You're doing home care, and then you're doing pediatrics, and you're doing cardiopulmonary and hospital care and all these different things. Um, so I said, I can still do this, and I had to prove a little bit to myself, and went out and, you know, kind of prepared with, give a shout out to the Orthopedic Academy with their preparation book. That was kind of the core of everything I did with it, and somehow the score came back, and it was a winner. So see now if I can keep up with all the other new requirements that you have to do every couple of years here to keep it going. But it was an interesting experience. I learned a lot about kind of the thinking a little bit of where orthopedics physical therapy is right now. Some surprises with it in terms of what was on the test, and kind of a little bit surprised by some of the things that maybe I thought should have been on the test.
That's always an interesting topic. And while I don't necessarily want to dive into the OCS exam by any means, I do want to talk about this concept of evidence-based practice, because
Yeah.
as you mentioned, you've seen over 3 decades of physical therapy. I'm going to go there. That's longer than I've been alive.
That's all right. I'm
So
still processing that. Yeah.
you have a lot of knowledge and experience in the world of PT from a variety of different angles, as you mentioned, and you've seen some very complex cases. You've seen the evolution of PT over the past few decades, and this concept of evidence-based practice continues to get thrown around a lot. And I find that a lot of times people's definition of evidence-based care or evidence-based practice is kind of misunderstood. So when you hear that term, what do you usually think of, or how would you define what evidence-based practice would be?
Yeah. I think, I still hang on, and maybe this is, outdated, but I still hang on to kind of the original Sackett, you know, definition of clinical expertise of the therapist, the best research that's out there, and then the part that often is forgotten about, and that really I've learned over the years to put much more weight on, is that patient values and preferences. So it doesn't matter if, the clinical practice guideline says, to do the manipulation, for when you see this, if the patient isn't comfortable with you doing manipulation. So you got to understand kind of where the person that you're working with is coming from, their understanding of the problem, their needs and goals. And that's really kind of the skill of over time that, if I could go back 30 years and put in my effort right from the get-go, I probably would have spent more time in kind of that, understanding and communication of the person who's sitting across from me with, whatever it is, back pain, leg pain, just had a stroke, all those things. Because that's the hard part. What we do usually is pretty easy, straightforward. There's time, there's things involved. We provide our guidance, but trying to get buy-in and then understanding, where that leaves that person you're working with that's really hard.
It definitely is. And, I'm still perplexed by this though, Matt. You mean to tell me I can't just look up the clinical prediction rule and say, yep, this is going to work? It really is a lost art of being able to communicate effectively with your patient, understand where they're at, where they've been, and where they need to go. And I think that's something that often gets missed in the evidence-based realm, is we focus sometimes too much, in my opinion, on the research, the evidence, and literature, when sometimes the best intervention for the person in front of you is the one that they can do, and not the one that holds up as number one on the EMG study.
Yeah, that's the saying, right? The best home exercise program is the one that they're going to do. So oftentimes it doesn't matter if you do your choices or this or that. What are they going to do? Because really you're seeing them, for just a snippet of their life, of their week. and a lot of what we do kind of relies on kind of them keeping it going when you're not in front of them. Um, and how do you communicate that and create that compelling story for them that they can understand and get buy-in, that you can provide that guidance and help kind of coach them through.
Yeah, definitely. And just having the ability to connect with someone early on and get to know them, because, PT is a unique field in the sense that we help people restore function and get back to doing things that they might not be able to do when we first see them.
Mhm.
So getting to really understand where they are and where they need to be, I think, is a lost art. And unfortunately, we don't have a clinical practice guideline for every one of those situations. We don't have a guide for getting post-op ACL patient all the way back to, NFL football, or, post Broadstrom procedure, or post, labrum repair back to X, Y, or Z. Like, we don't have guides for every single thing getting back to every specific activity.
I think about my friend Rob DeBee, Dr. Rob DeBee. He's a physical therapist, epidemiologist over at Maastricht University, and he's done some great talks about evidence-based practice. But one of his lines is, you have the clinical guidelines, but they're, he tongue-in-cheek kind of says they're guide lies, because until you whittle it down as an epidemiologist, you're creating the study about, the person who just has back pain and they only had it for 3 weeks, and you want to know what that's like. But like the people we see in front of us in the clinic from day to day, have had back pain for 6 months. It's their third episode. They're out of work. They have diabetes or pre-diabetic. They might have high blood pressure. All these other confounding factors, that the studies, kind of weed out and don't talk about. So, and we talk about that in the class at LVC, is really, it becomes an N of one. You have to be able to assimilate that information, take it in for what it's worth, as to help guide you a bit. But ultimately, it's like that person in front of you, and you got to understand it. It's about the patient.
Yeah, ultimately, that's where it comes from. It starts with the patient. It has to be patient-centered, patient-focused, whatever their goals are, whatever their abilities are, and whatever they're comfortable with allowing you to do. You mentioned it initially when we started talking about this, is some patients might not be comfortable with manipulation for whatever reason. Others might not love dry needling. Others might not like cupping therapy. There's a variety of different interventions that we have at our disposal that patients might not like. And, I don't think it's our place to force those on someone, even if they might work for them. I think it's better to meet people where they're at and offer them what they feel
Yeah.
is best for them, even if you might feel otherwise, or you might have an article that cites something differently.
Yeah. Yeah, and that's the thing. I mean, we have, as you gain more experience, you develop this wealth of skills, and what you come to realize is there's not the silver bullet. Just because they might, you know, the research says this is the thing to do. Well, especially in physical therapy world, nothing is particularly compelling. There's nothing that says, do this on people with back pain and they're all going to get better. Well, some of them do, but we also know that you could do not do manual therapy on somebody with back pain, and you know what? They get better. Um, so you have to have that flexibility, and that is another element that when I think about evidence-based practice is kind of being flexible, having that ability to kind of understand the situation, be flexible. What are the things that are at your disposal? How would those apply? What are the potential outcomes, pros and cons of it? And then you're providing that information back to the patient in a way that kind of guides them and helps them make good choices. But ultimately, it's their choice, and you have to respect some of that.
Yeah, definitely. Do you feel that assumptions are made as part of evidence-based care when working with a patient? And do you feel like most clinicians are aware of the assumptions we make while we're working with a patient? Or do you feel like we just kind of fill in the dots as we go, and put the pieces together.
Yeah, that's the thing I struggle with all the time, that realization of like I have biases that I'm aware of and I have biases that I don't even know, that, I don't have awareness of, that, from time to time a patient or, person I'm working with will call me out on. Um, and I have to accept that and acknowledge that. And also kind of tell my patients that too. I'm like, look, I look at things a certain way, and this is how I see it, and tell them why. Um, and helps me being honest about the situation, and my skills and what I can do to help them with and what I can't. Um, because there's so much information out there for people, from media and social media and television and everything else under the sun, that you're competing with, that, we're also affected by that. And you have to kind of accept that, where you're at, where you're coming from, and kind of talk through, and give it that, just be honest about it. And that's another piece, I think, is just that clinical honesty that you have with yourself and with the person, your client.
And that's sometimes kind of difficult, or at least it
Oof.
has been for me. It's not always easy to look at someone and say like, "Hey, just so you know, you're going to be the first one I've rehabbed with this condition," or "Hey, just so you know, I'm not 100% sure where we're at right now. I've never been in this situation before." But what I've found is, and this is one of those cliche terms about people don't care about how much you know until they know how much you care.
Mhm.
At least in my own experience, as long as you're upfront and open to telling people like, "Hey, I don't know everything, but I'm going to do the work and put in the effort to figure out what we need to do and how we're going to get there." As long as you do that, I found most people are okay with it. They're open to it, and a lot of times they actually respect it more than you just being, the guy who knows everything. You've got it all under control. You've got it all figured out, done it a million times, and next thing you know, you find yourself in the middle of a dumpster fire.
Oh, yeah. Yeah, that's for sure. I mean, when I first started to practice, back in the 90s, it was, the mentality was everything that came through the door, didn't matter. So, I can remember, having a patient with a chronic shoulder problem who, they wanted to do surgery, but he didn't want to get surgery. But the confounding factor was he was deaf. Well, I never had a class in, working with somebody with hearing impairment. Um, but, we figured it out, and, was able to help them. And, you know, one of the advantages I have of kind of having my own independent contract, practice, and seeing private clients is, I say no. I'm not the guy for everybody. Um, but I also have to be willing to help them connect through and navigate through the healthcare system and get them in front of the right person. And that's just, you know, such a better place to be in sometimes. I've worked in kind of the big box, you know, facilities where no matter what, you didn't send somebody away or send them somewhere else or whatever. God, you tried to figure it out. And sometimes it's just, hey, like I know Dan, he's like an expert, and he just did this class in dry needling. I have no idea. So let's go send you to Dan. Um, so you have to be willing to do that, and it's probably a little bit easier these days than it was long ago. But it's still hard to kind of understand like what's in your wheelhouse, and who you can help, and sort of that recognize your shortcomings and defeat early, but be ready to move on and give somebody else that victory, to send them off to somewhere where they can get help.
Yeah, I love that. And that's something I find a lot of people are not willing to do. And I like your point too about recognizing your shortcomings, because we as a profession have changed and evolved drastically over the
Oof.
past few decades.
Yeah.
And if you don't believe me, flashback 30 years ago, see if you can find pictures online and see how many clinics had ultrasound units everywhere.
Oh my goodness. Yeah.
Pull up pictures or walk into a clinic now and see how many
Yeah,
you see in the clinics. You know,
yeah.
they're kind of, or at least in the clinics I've been in, they've been disappearing.
Yeah,
Um,
one of the
for
classes, first classes I was in adjunct teaching, was filling in for somebody who was on sabbatical, was teaching modalities course. So it was diving into ultrasound and diathermy and, stuff you probably never even heard of anymore. So I was pretty up on it, and I got to the end of the course and I was like, man, this is just crap. It doesn't do anything. There's no evidence for it at all for anything. And honestly, like if I walked in somewhere and had to do an ultrasound on somebody, like I don't think I could do it. I don't, I'm,
um,
I would have to, throw up the white flag and let somebody else do it because I haven't touched an ultrasound or any of that for, I don't know, ages and
Yeah,
ages.
yeah. No, I don't even know if I know how to turn the machine on anymore. But yeah, it's one of those things where our profession has changed and evolved, but we have to be willing to be open about that and accept that. You know, we can't be using ultrasound one day and then the next week turn around and bash ultrasound. We've got to
Yeah.
admit, like, hey, this is where we once were. This is
Mhm.
what we thought. We were wrong. Here's
Yep.
what we're doing now. And that sort of thing is common practice and standard in the healthcare system.
Mhm.
Surgeons change techniques all the time. I've seen great surgeons who slightly disagree over certain things, like, you know, should an ACL reconstruction be given a patellar tendon graft or a hamstring graft, or
Right.
maybe the quad tendon graft? So I think that we as PTs need to do a slightly better job of accepting that, hey, we're not perfect and that things are going to change and evolve. And that's part of evidence-based practice is constantly changing and evolving over time.
Yeah, I think it, comes down, and I'll steal, the pop culture from Ted Lasso about, my favorite scene from that was when he talks about being curious, not judgmental. Um, and I try and play that in my head, through the day when I think about care for clients and patients is, what's really going on here? What can I do? And being curious about it. And just as, a professional identity of kind of like, always moving forward and trying to understand what we have in front of us and what's available.
Yeah, yeah, no, I completely agree. I like that point. Where do you think the evidence fits into evidence-based practice? Where do you think the research articles and RCTs and case studies and CPGs and all that stuff, where does that kind of filter in? And,
Mhm.
you know, is there value in some of the quote unquote lower level evidences like the case studies? In your
Mhm.
opinion, or are you going straight to your RCTs, meta-analyses, that sort of thing?
Yeah, so as a busy professional like you, right? The question is, where do I put my time? There's information everywhere, right? It's
Right.
information overload. I can remember working on, putting together conferences and courses on the shoulder and back and things like that. And I just hunker down in the library with, a sandwich and some water and I'd be there for a weekend, just like piling through all the, hard copy and photocopying stuff. Now, I don't have to leave my couch. You just have access to everything. So it becomes what's important. Um, I think you have to go through and I get, the main journals within physical therapy. I scan through them, um, and honestly, there's so few that studies these days that really kind of change how I think about things. It takes a lot to, create something compelling that's going to like, man, I gotta, I've been going this one direction with something and I gotta go a completely other direction with it. Um, we had this talk a couple weeks ago when we were trying to set this up. I know about dry needling, and yeah, I think, sure, could be useful, could be valuable. Am I going to do it? Probably not, because I have a bunch of other things that, and from my information and what I understand, are just as effective, or pretty darn close without having the same level of commitment to to that you get with something like dry needling. So, it it's kind of understanding where the evidence is, what the value is, and does it really kind of shift or move the needle for you. And there's a few things that I think it's hard to do research in the types of things that we do as physical therapists. I mean, we all know the big players in physical therapy research. Julie Fritz comes to mind as kind of the main person in orthopedic anything doing research, and there's others out there. um, but like how much of it really changes what we're doing, because it's hard to get enough numbers of patients to do really good studies. And we're trying to set up these networks, um, to do bigger numbers, and to try and get other large healthcare systems to kind of network and share data. um, I worked in the insurance industry and workers' comp for about 5 years, and we had, tens of thousands of, data elements. Um, and man, it was an uphill battle to get access to it, to get stuff out there. Um, so I think we have to be comfortable with a lot of the studies. Most of the studies we see in JSPT or PT Journal, they're going to be small. They're going to give you an idea or a different way maybe of thinking about it a little bit, but it's probably not enough that's going to most of the time really change what you're doing. But you got to keep your eye on it, because every once in a while there's something that comes out where it just kind of shifts the thought process.
Yeah, no, definitely, Matt. There are some things that certainly change what we do, and some other things that, we look at them and it's like, okay, that reinforces what I'm doing, but I'm not going to change anything. Or maybe, hey, that doesn't really reinforce what I'm doing, but it doesn't show me any better option or better alternative out there. So I like your point about that. And I think one of the most unique takes I've had on this from Rob Butler a few months ago on the podcast was he kind of explained it in the sense of there's a lack of a common language in a lot of
Right.
these things. And I think we in PT fall victim to that ourselves. Is
Yeah.
the way you describe an exercise is going to be different than the way I do it. So as a
Yeah.
result, it's going to have a different outcome. If I cue one thing and you cue a different thing, that patient might feel something completely different. So I
Yeah.
think it becomes very difficult for us to research things in depth and detail and then apply them on a broad scale when we don't even have a common language to communicate about these different things with.
Yeah, I think about two things there. One, I'll just, throw this out there is, define core, right? We talk about it all the time. What is it? Drives me a little crazy because, there's no agreed upon set definition. Um, we'll set that aside for another talk, another day, maybe. But really go back to kind of my good friend and mentor, Roger Nelson, who is kind of one of the main forces in our guide to physical therapy practice. There was a time when we didn't have a common taxonomy within the profession. Like it just, imagine we didn't have a way, to your point, of communicating with each other, and nonetheless try and communicate with everybody else in the health community, to understand what we were doing. And we probably don't spend enough time on that, as professionals, to go through and make sure you're up on. The guide was just updated recently. Like, go back through and go through it and pick it up, and because that's our language. That's what we have to kind of help define our profession. And because we got to at least communicate with each other, and kind of hold up kind of our value to the rest of the healthcare community and to our patients. And it all kind of starts from having that agreed upon or defined definitions of the profession itself.
Yeah, it starts with the common language and the ability to communicate with one another. And then it takes a step further, I think, going back to what we just talked about on the research and that sort of side of things here. I think a lot of the research is great, but a lot of it too is slightly vague. Even sometimes the CPGs that I look through, they don't necessarily come out and give you a template for when you have this diagnosis, this is the exercises, this is how you progress. They'll tell you, for PFPS, you should strengthen hip and knee musculature. But they're not going to tell you what exercises to do for that, because that's where the art of what we started talking about at the start of this comes in. Your ability to connect with your patient, figure out where
Mhm.
they're at, and then develop a treatment plan and treatment program for the person sitting in front of you. And at least in my experience, I'm trying not to be one to throw stones at glass houses in the education system. I take that term from Brian Carden, but
Yep.
I think that in general, a lot of PT programs, at least in my own experience, have kind of skipped over the exercise intervention side in
Mhm.
favor of a lot of hands-on manual therapy type stuff.
Oof. Yeah, boy, you got a hot button for me, right? Yeah, I have to be careful because I could tell some stories and we will protect the innocent or the innocent in intention here.
Yes.
But yeah, you're absolutely right. I mean, probably the most fun I've had as an adjunct, over gosh, it's been 20 plus years just at LVC, along with a bunch of other schools now, but was teaching exercise science because I think that, in and of itself becomes one of the core of who we are. If we really are the movement specialists, um, as physical therapists, how does somebody get from A to B and do that efficiently, effectively, in a manner that they, appreciate? You're absolutely right. We have to really understand exercise, what that means, and have that, as fundamental as understanding neuro, as understanding gross anatomy. um, you know those are really important. I mean, to me, honestly, the manual therapy is great. But man, it doesn't take that long to get good at it. Like, it's pretty straightforward if you know your foundational stuff, if you know your gross anatomy, your neuroanatomy, you understand exercise and load and recovery. Then yeah, then the manual therapy is, it's pretty self-evident then, like, you know which way does the glenohumeral joint move? Well, like, it's shaped this way because I know the anatomy, so it moves this way, so let's do it. um so I think you're absolutely right in that there's kind of that underappreciation for kind of those foundational elements of our being a physical therapist.
Yeah, definitely. And taking your point on that a step further, I know this is a evidence-based theme discussion, and I don't have any articles or resources ready to cite on this claim, but I can't help but wonder, does the difference between a grade 1 and a grade 2 mobilization really mean anything?
What?
Or like, are they even doing what we think they're doing in the first place? Don't get me
Mhm.
wrong, I think manual therapy is a powerful tool. I think that
Yep.
it's great that clinicians need to be good at it, but do we really care about some of those subtle differences like grade 1 versus grade 2? Or are we okay with just accepting like low grade, grade 1 to 2, mid
Yep.
grade or higher grade, grade 3 to 4, something like that?
Yeah, no, I went through that, long ago. I can remember my training of, the four, five different grading of how much force you're applying. Um, when really it was just kind of think about, what's the end result of what you're trying to accomplish, and then think about that person in front of you, and then, it becomes evident of how much force you're going to imply there. Um, I think you're right. We kind of try and be too precise and too specific about things in ways that aren't really measurable. We could say the same thing about manual muscle testing. Are they a three, or are they a three plus, or are they a three plus plus? Um, you know, doesn't matter. Can they do what they need to do? Can they get up out of the chair, or go up the stairs, or throw a football 60 yards?
My
Um, you
my
know,
uh my favorite one recently has been the addition of the 5 minus to the scale.
yeah, yeah.
I completely missed the 5 minus before. It's amazing how some of those little things kind of get thrown in there.
We did a study. So when I worked with the workers' comp insurance company, we looked at 300 cases, where we had a clean case, meaning that we had an initial evaluation and we had a discharge. And the nice thing about, workers' comp is your goal is defined for you. They're back to work. So you have that preset for you. So it allows you to do a lot of things. And what we looked at was just that simple comparison of, if they looked at all these impairments on the initial eval, did they ever look at it again? Ever? And the answer is, we started with this, if we broke it down, did all this work on the shoulder and how many planes of movement on the shoulder could you do and test, and had all this, and the we did the initial run on the analysis, and it was miserable. Nobody did anything the second time to get a comparative. So then we said, well, if they did active range of motion, we just left it at that. Did they ever do active range of motion again? And even that was, woeful of, I think 6 to 10%, if I recall the numbers with it. So that's part of kind of evidence-based practice, is understanding kind of what's important, what can you measure with any kind of degree of accuracy that matters, and that matters to the person, to the patient. But you got to do it again, right? You can't just do it once. You got to have some core things that you're going to track and follow that give you those, mile markers along the path. It doesn't, I know Dr. Nelson used to talk about, if you're going from Philadelphia to New York City, well, there's a dozen ways you could go. It doesn't really matter. You're going to end up in New York City, but, you got to know, you're on the road, you're on the, you're getting to the exits, you're hitting the mile markers, so you got to track those things as you go. And again, as you alluded to, it's probably an underestimated or underappreciated piece of being an evidence-based clinician, is, having that foundational understanding, what we're going to measure, why we're measuring it, why it's important, communicating that to the patient. And then you got to continue it. You got to stick with it. You can't just throw in other stuff.
Yeah, and be consistent every time you do it. So if you're going to take a measurement of quad circumference, do it in supine every time. Don't do it supine once and then standing the next time. Keep it consistent. I'm curious to hear your thoughts on this. I know there's been a lot of technological advancements lately, including like digital goniometers to help try and improve our accuracy on some of those objective measurements. Do you see them being kind of like the future of objective measurements, or do you think there's nothing better than the time-tested original Goni?
You got to be fast and efficient, and understand the accuracy of what you're doing, and what's important. So, honestly, I had my goniometer out just this past week for probably the first time. It took me a little bit to dig it out and find where it was in my bag. And somebody with an elbow fracture that they never got treated, and now here we are 12 weeks later, and they're 15 degrees short of extension. So there was a real purpose of why I brought that out, because I wanted the patient to understand, here's your non-injured side, and look, this is where it is, and I could hold up the goniometer and show them. And then here's where your injured side is, and hold that up and give them that real visual, and then say, okay, we got to go, that 15 degrees, that means it's going, watch the arm, it's going from here to here, and give them that visual and help them understand that. So that's where I find those things are valuable. But most of the time I'm like, can you touch the top of your head? Can you touch the back of your head? What can you do functionally? Can you get it up overhead? Especially with the spine, I'm probably just providing some estimates of, it's restricted and painful, or it's not restricted and pain-free. How far is it supposed to go is, up for debate sometimes. It's a matter of how far does it have to go for them to do what they want to do. So, how am I measuring that? I don't know that it's quite so important with some of the technology. I've gone back and forth about getting myself like a manual muscle tester, digitized, but I don't know that it adds so much to to what I look at and whether it becomes important for, at least for the patient clients I do.
Yeah, no, I love your point on, just the general things. Where can we move to? Do we have restrictions? Is it painful or painless? Is it strong or is it weak? Is it strong and painful or is it weak and painful? Adding those kind of things into it. And the one thing I wish I did when I was just out of school and measuring and tracking some of these things in my first evals is I didn't pay attention to medications. So what
Oh
I mean
yeah.
by that, I would ask about it in relation to like the medical stuff, but when it came to the pain side, I'd have people on eval who were moving without pain, but guess what? An hour before they came in there, they took a few
Loaded up.
things.
Yeah.
And then,
Yep.
we do our progress report 10 visits later, and what do you know? It hurts. But guess what? They're not taking the medication anymore. So is that a failure of me as a PT? Is it a success of me as a PT because they're not taking the meds anymore? And that's up for debate, but that's one thing that I wish, like for myself, that I paid attention to more when I was starting out there with that sort of thing in the ortho realm. I'm
Right.
also curious to hear your thoughts on, we look at objective measures all the time to show progress. And as according to a lot of evidence practice, that's what we need, objective improvement. But I feel like there's a lost art on the subjective side, kind of like we alluded to earlier. The patient kind of has to be the focus. And sometimes we see objective improvement, but the patient doesn't feel any better. And
Mhm.
what do we do then?
Yeah, yeah, I can think of, a couple cases, one in particular of a client at a chronic pain clinic I worked at for a number of years where, pretty horrific injury. So she's sitting at an intersection on her way to her accounting job in the morning, and a dump truck in front of her, the dump starts to lift up and like dumps like a ton of stone onto her car. And she was trapped and for a couple hours, and it was pretty horrific, traumatizing. We had her on a multidiscipline chronic pain program, seeing psychologists and the whole 9 yards, everything, for 8 weeks. And she's doing everything. I mean, she's doing like 4 or 5 hours of activity through the day in our clinic with everybody. And go to do the reevaluation, and it's just like you alluded to, she doesn't think she's better, and we're like, that's where you got to go. Remember, we picked up this box on day one and tried to pick it up off the floor, and you couldn't do it, and now we got 30 pounds in this box. So those are the types of objective measures that can be helpful. But you have to help that patient perception of where they're at and what they understand. And sometimes we see people who go through, really traumatizing episodes. It takes a while for them to kind of get, not just physically heal from, but mentally recover from. And that's part of it. And that's where your objective measures to help them understand become more important, not just in, hey, they can, lift this now and all those types of things, but helping them understand kind of, you are stronger. Look at, where you were. And that's, again, where you have to be precise about your initial test, and even descriptive, so that you can repeat those conditions again later on, to your point of, what was the time of day, what medications, and accounting for all those things. And that's kind of that, again, a little bit of those nuances of sort of being that, expert clinician and having that understanding of things.
It's amazing how we call the field physical therapy when in reality the mental side has so much to do with it, isn't it?
Yeah, if I could have spent more time on that back in the day, I, probably would have saved myself a lot of work and effort.
Yeah, and sometimes a lot of the mental challenges we find that might lead someone to report, hey, I don't feel like I'm getting better. To me, anyways, and what I'm seeing on a clinic side right now, I think some of it comes from the nature of the rehabs, right? Like I've got 13 patients who are ACL patients on my caseload right now. So it's like you look at, the average length of rehab for someone recovering from an ACL tear. I mean,
Yeah,
that's a
it's long.
long time.
Yeah, it's
So,
longer than anyone will tell them. That's usually what I say. It's longer than your physician will admit to. It's longer than anyone will tell you. Um, and we see that in kind of that high reoccurrence rate with things. That has to be some of the factor, Uh, they see these athletes, professional athletes. We're dealing with that with Philadelphia Phillies now. You see Bryce Harper coming back from his ulnar collateral tear, in record time. Um, well, he's not really, I mean, he's back, but he's not throwing, and he's got a road to go yet. And most of the evidence and experience you see, it's like these things take a long time. And that's where kind of that mental, those coaching aspects of, keeping them motivated, keeping them focused, being with them for those, inevitable ups and downs that they're going to have. You got to have that in your skill set. And as you said, you have to recognize those things, where are they at today? And what can I do to kind of keep them motivated and positive? Even if I'm not having the best of days, my day can't become their, my bad day can't become their bad day. You got to, takes a lot of energy and brain power to kind of keep them, clients like that moving. So
ultimately, while we've discussed a lot in almost an hour so far, we've really just tipped the iceberg. And the world of evidence-based practice is ever changing, ever evolving. And unfortunately, there's not really one right answer to everything. But, I think as we've talked about, the importance of listening to your patient, the importance of being open and honest, the importance about trying to stay up to date with things as much as you can, and recognizing what you do know and what you don't know, and when to call for help when you need it, are probably the biggest things that come to mind for me. Do you have any other kind of takeaways or thoughts or remarks that you can think of, or anything that we might have missed today?
yeah, I'd just say, and sort of touched on it, is that important piece of, you got to have your network of people, you got to have your mentors. I wouldn't be anywhere without the people who helped me along. My, mentors from my powerlifting coach, Jake Boyer, who got me into the profession to start with, to Dr. Gary Mattingly, who, helped my love for anatomy and gross anatomy, to Carolyn Barnes, our department chairman, um, and John Barbas, physical therapist, just master clinician here in the Philadelphia region, and of course Dr. Nelson, from Lebanon Valley College, and who just uh, changed everything for me. People who gave me opportunities. You got to have those people along the way, because you can't, you know, you don't know what you don't know yet. So if you have somebody who's been there, can help you along, answer those questions, keep you accountable, listen to your stupid ideas and then tell you to get back to work. You got to have those people in, and that's part of, what I hope, especially new clinicians appreciate. You got to have a network of people that you can rely on and trust, that you can call for those things.
Yeah, no, you're exactly right. And I'll take it a step further and say, don't limit your network to just PTs or just
Yeah.
MDs. Fill your network with a lot of different people from a lot of different backgrounds. I had a 45-minute call earlier today with a strength coach in regards to someone I'm working with. And a lot of people look at that and think, okay, wait a second, you've got the doctorate degree, he only has a bachelor's. But I'll be honest with you, I learned a lot from this guy in 45 minutes
Mhm.
on the phone. And I think that, in a world where we value a lot of the degrees and statuses and fancy letters after our names sometimes, there's a lot that can be learned from just talking with other individuals in a similar space to us.
Yeah, and I'll give you credit, for what you've kind of built here with your podcasts, and just, I hope people appreciate kind of the breadth of expertise that you're willing to bring in, from across the board. You're talking to anybody and everybody about what they know, what they think, and some you can, kind of say, well, that world probably doesn't work like that. But I think it's important to have their perspective on things, and just, absolute credit to you with what you're doing. Really a credit. Hopefully, LVC or alma mater recognizes you a bit for some of that and helps you. But I certainly appreciate what you're doing.
I appreciate you bringing that up here, Matt. And, like I said before, I certainly don't know everything. And to make sure we never stop learning and never stop looking for the next thing. And I think it's essential that we all sit down and try and take something away from others' experiences, because while we didn't necessarily get into it a ton, that's kind of the last piece of evidence-based practice
Yeah.
is learning from others' experiences and trusting expert opinion, and where decades of experience comes into the whole process.
Yeah, that's certainly part of it. You gotta be open, and we'll just come back to you. You just gotta be curious. Ask questions.
Definitely. Matt, thank you so much for your time today. It's been awesome.
Yeah, this has been great fun, Dan. Thank you for the opportunity.
Hey everyone, I want to take a second and tell you all about AliRx. AliRx is a at-home food sensitivity and gut health testing panel. You order online and then receive and complete your test at home for food sensitivities. You then receive a custom report online through your member portal, and then receive personalized recipes and supplements that are catered to you based on your food sensitivities. If this is something that interests you, you can check out the link and description in my bio, and you can use the coupon code capital D, capital B, RAUN, capital RX, so D Brawn RX, at checkout to save yourself 20%. Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.